All right, let's start talking about the abdominal organs. So take a moment, deep breath, and enjoy the funny comic here. I usually like to give this one and post this comic as a result somewhere around St. Patrick's Day, but since everything is topsy-turvy this year, you can just enjoy it now. And let's get started with the abdominal organs by talking about the teeth. Now, the teeth and the oral cavity are basically the first part of the digestive system, so that's why they're included here. So a little bit of a tease there. And you guys are not training to be dentists, so we don't need to go into extreme detail, but it's worth knowing a few things about the oral cavity in relation to the digestive system. So, basically, as little kids, we have deciduous teeth, 2 incisors, 1 canine, 2 molars. And as those are shed and the mature teeth grow in from tooth buds that are developing within the jaws, the maxilla and the mandible, they're going to be replaced by 2 incisors, 1 canine, 2 premolars, and then 3 molars. And that third molar is the wisdom tooth that may or may not show up, might grow in a wonky way, and you just want to be aware that that wisdom tooth might not be constant in everyone. The teeth themselves are mineralized tissues with a pulp root kind of at their base, with blood vessels, lymph, and nerves actually coming into the pulp chamber here, and we have a layer made of dentin making up the majority of the tooth. Dentin is a fairly tough mineralized structure. It's held in the socket by a periodontal ligament, as well as cementum, another mineralized tissue that basically anchors the tooth in there. Now, the presence of that ligament is actually a very important thing, because we wouldn't want the teeth to be rigid in the jaw. We want a little bit of flex, because without it, the teeth would tend to shatter. So it's good to have a little bit of flexibility there. Think of a tree. If it's too rigid, it's going to snap in a storm, as opposed to a willow, which is able to waver and snap back a little bit. Now, another thing about that is that because the cementum, ligament, and bone are able to respond to each other, you can actually have deformation, or, if you prefer, correction of the tooth positioning over time. So click on this link if you want to watch a sped-up orthodontic time-lapse film of a girl's teeth being straightened over several years. Now, on the very top outermost part of the teeth, ideally, we've got enamel, the hardest naturally occurring organic substance, and it is another mineralized tissue, and essentially it should dip just below the gum line and resist abrasion, allow you to chew things up, and if you have the gums withdraw so that the line of dentin gets exposed. Dentin is a mineralized tissue, but it's nowhere near as tough as the enamel, and it tends to erode a little more easily. And that can lead to cavities. So here we've had withdrawal of the gums, exposing the dentin, and that's been eroded by bacteria. Now, bacteria aren't going after our teeth per se, they're just going after whatever food remnants are in there. So if you're not already a regular flosser and brusher, I really recommend you start, because if you've got gunky food stuck to your teeth for any length of time, those bacteria are going to come in and they're going to digest it. And they digest it the same way we digest food. They release acids into the immediate area. And one thing that acid can do to these minerals is denature them. That low pH causes the minerals in the enamel, or in the dentin, to come out, go into solution, and basically we create caries or cavities in that way. So one, you want to make sure that the enamel is healthy and that the gums come up to it. And two, you want to make sure that you have good oral hygiene, or encourage your patients to have good oral hygiene, because it's very easy for the bacteria to set up shop in a place that's got a lot of food stuck to it and burrow into the tooth. The tongue is an underappreciated digestive organ, and we've talked about its innervation with the hypoglossal nerve, the various taste buds. Now let's talk about the taste buds themselves, independent of their innervation. Most of the tongue is covered by what are called filiform buds. These are basically our filiform papillae. These are little sharp, spiky things that create a roughened surface on the tongue. The fungiform papillae are these little bumps. You can see them on the tongue. I might be the only one, but I tend to get these become kind of enlarged and painful for me whenever I have some like Sour Patch candies, so I try to avoid those now. If that is something you're not experienced with, then just run with it. But those fungiform papillae do have taste buds around their circumference Then we come to the division between the anterior 2/3 and posterior third of the tongue, and that's marked by these circumvallate, or very large circumferential papillae right here. They have lots of taste buds around their periphery, and along the edge of the tongue we have foliate papillae. These little folds along the lateral side of the tongue, also containing taste buds, as well as some secretory glands to help wash debris and other stuff out of the area. So let's take a look at these. In a histologic section, we have the filiform papillae, these little spikies right here, and if you have any cat owners in the house, that is exactly why cats' tongues are so rough. They've got these filiform papillae really well developed to groom themselves. Now the fungiform papillae are these little guys here. They have some taste buds up on their surface, poking up, and those are sensory organs that sense what are called tastants in the stuff that we eat. We'll talk about those in just a second. Here's a circumvallate papilla, and I want you to notice the taste buds here and here are actually the same size. It's just these circumvallate papillae are really huge, so this is a little more zoomed out photo, but the taste buds are equivalently sized. So fungiform papillae, much smaller than these big circumvallate papillae. And notice that there's a moat around them, and there's a lot of glands releasing serous fluid, kind of watery fluid into the area. That helps wash these areas out so that you can get taste sensory receptors exposed to the stuff that's in your mouth. And the foliate papillae are also large, and they just form these regular sheets with invaginations, also serous glands there to wash them out and expose taste molecules to these taste buds. There we go. Now, taste buds are innervated by cranial nerve 7, 9, and 10. They have a cluster of cells just underneath the tongue surface that have microvilli sticking up into a little taste pore right there. Now, what I love about this is that the structures that are sensed by these microvilli and their receptors are called tastants. So tastants are the actual things that trigger these microvilli and their receptors to signal sweet, salty, sour, and so on. Now, our tongue does not have a sensory map on it like you may have been taught earlier on. There's not really a salty area, a sweet area, but there are little clusters that are more prominent in others, but not really a super specialized area. One thing that you might have experienced when you had a viral infection is that sometimes you'll have viruses attack these cells, and as they do that, it screws up the way that they signal the nervous system, and they start firing in kind of unusual ways. So if you've ever been sick and just had food taste weird for 2 or 3 days, that's what's going on there. These cells got attacked, they weren't working properly, but every 10 days these cells are replaced, and so once enough new taste bud cells are in the area, your sense of taste goes back more or less to normal. Alright, so now we're out of the oral cavity. We're going to move into the esophagus and all the way down the digestive tract. To do this effectively, we're going to work through what I like to call the generic gut tube, a version of the gut tube that is more or less standard from top to bottom, and the innermost layer is called the epithelial layer. So we've got the lumen here. That's where food is actually hanging out. And then the epithelium is surrounded by what's called the lamina propria, an area with very loose connective tissue that allows things to diffuse into this area from the lumen relatively easily. There's a thin rim of smooth muscle around the lamina propria called the muscularis mucosae, and those little red dots are signifying that there are small vessels in the lamina propria as well. So at this point, theoretically, we've got a gut tube. We've got an epithelium that keeps the outside lumen separate from the body tissues. We've got a lamina propria with blood vessels in it that should technically, theoretically, be able to transport digested material into the bloodstream, and we've got muscle around it that can actually absorb, well, pardon me, not absorb, but move things along, peristalse things along. Theoretically that works, but our gut tube has much better structures to do many of these things. First off, we have a layer called the submucosa, and the submucosa contains very big vessels and glands and things of that nature that allow us to absorb these nutrients in bulk. Also, we have not one, but usually 2 outer layers of smooth muscle. This is the muscularis externa, and it's got an inner circular and outer longitudinal layer to really kickstart peristalsis strongly. There's a few modifications of that in other parts of the body, but we'll get that as we go. And lastly, we have an outer layer that either anchors the gut tube in place or allows it to slip around within the peritoneal cavity. This is called the adventitia, if it's anchoring in place, and it's called the serosa if it's going to be lubricated, release a little bit of fluid, and kind of slide around inside the peritoneal cavity. So this is the generic gut tube, and we're going to really discuss all the other parts of the gut tube in reference to how this plan is modified. So now let's talk about the different layers of the generic gut tube. The first three layers, the epithelial lining, the lamina propria, and the muscularis mucosae, are grouped together and termed the mucosa. So whenever we talk about the mucosa, we're talking about all three of those layers. And these are the layers that really have to do the most difficult part, which is reconcile two contradictory functions for the GI tract. You have to extract nutrients from food, so you want a lot of stuff coming out of the lumen into the bloodstream in bulk. And you want to protect the body from pathogens, which are also trying to move out of the lumen and into the body to infect us. So the mucosa has to do two things that really don't get along. And so essentially, we've got the three layers to help with that. The epithelium tends to be stratified squamous in the upper part, like the esophagus, or simple columnar, where we're doing a lot of secretion or absorption. Then, the lamina propria is made of loose connective tissue, and a lot of immune cells migrate into and hang out in the lamina propria to respond to immune challenges from the GI tract and pump out antibodies, immunoglobulins in response to that. And then the muscularis mucosa is smooth muscle that helps milk everything along. It's not terribly strong, but it does tend to help move things along a bit. Now, outside of the mucosa, we have the submucosa. And basically, it's going to be the place where the large vessels and nerves are hanging out. It's also got nerve cells within it called submucosal ganglia. And just a quick preview, these are the postganglionic parasympathetic cell bodies that we talked about when we were discussing the autonomic nervous system earlier. There are glands in the area, and there's going to be large lymph nodules there to assist in generating a sustained immune response, but also keeping the beneficial gut normoflora in state so that we don't kill off all the bacteria in the body, because some of it's actually very useful to have. The muscularis mucosa is typically two layers of smooth muscle, an inner concentric or circular layer, and an outer longitudinal layer. And you'll find more postganglionic parasympathetic nerve cells between those two layers. We refer to these as myenteric ganglia between the two muscle layers. Now, it's like, I like to think that the mucosa theoretically could do all the work, but we needed to rev it up a little bit and add the submucosa and the muscularis externa in order to actually make this work efficiently and effectively. And I'm hoping this reference isn't too jaded for y'all, but just bear with me. So, okay, mucosa, I'm going to let you finish, but the submucosa and muscularis externa are some of the most efficient gut tube components of all time. Of all time! And there's poor Taylor Swift mucosa just hanging out there looking sad. All right then, so now let's go to the final layer, the adventitia and serosa. These are going to be one or the other. You don't have both. You either have adventitia when you're anchoring the gut tube to nearby structures, like the esophagus being anchored in the mediastinum, and you'll find loose connective tissue nearby, and serosa when you have the gut hanging out inside the gut, inside the abdominal or peritoneal cavity. So the serosa is going to be a thin layer that secretes some serous fluid to keep things lubricated. And when you have inflammation or lack of lubrication in this area, you can get adhesions between the gut tube and the body wall. So that's bad news, and that's one thing that the serosa tends to help us avoid. We've gone through basically the generic gut tube and the different components of it. So now we're going to start marching our way down the digestive tract and take a look at each organ. So starting from the oral cavity, we go to the oral pharynx, into the laryngopharynx, and then to the esophagus. So the esophagus gets the chewed up bolus of food. It's going to move through the upper esophageal sphincter, or the cricopharyngeus muscle, and it's got a mucosa made of stratified squamous, non-keratinized epithelium. It's not keratinized because we don't have to worry about water loss through there like we do with the skin. It's stratified squamous, flat, stacked cells, and that tends to be something the body puts in places that have to deal with a lot of abrasion. So if you think about chewing on some Doritos or Captain Crunch and swallowing it after you maybe haven't chewed it as thoroughly as you should have, and you feel it scrape all the way down, thank your esophagus for having that stratified squamous epithelium there, because it's helping protect against abrasion and rough treatment in that area. Then we've got the lamina propria, a very thin layer here, and a little thin, indistinct muscularis mucosae hanging out here. Don't worry if it's not super distinct. The esophagus doesn't have a hugely noticeable lamina propria because it's not an area that has a lot of absorption happening. The submucosa is very noticeable. It's connective tissue with larger ducts, glands, and vessels in it, and then layers of smooth muscle out here in the musculus externa. And I say smooth muscle, but I should be a little more specific. In the upper third of the esophagus, we have skeletal muscle. The middle third is mixed skeletal and smooth, and the lower third is all smooth. Now, there is a disgusting little game you can play at home when you want to. Just make sure you use a small bite of food, but since we're not in the classroom right now, feel free to indulge at your heart's delight. Essentially, you can detect where the skeletal muscle and smooth muscle transition happens in your esophagus by taking a small bolus of food, swallowing it, and then bringing it back up into your mouth. If you can do that, you've only got skeletal muscle. You're able to control that bolus of food up and down, up and down, up and down. But if you swallow just far enough, you're going to reach a point of no return when the smooth muscle, the involuntary muscle, takes over and the food's going down to your stomach. Now, don't try way too hard or you might actually throw up, but you can have a little bit of fun in these trying times by checking out the skeletal versus smooth muscle activity of your esophagus. All right, enough said. At the bottom of the esophagus, we reach the stomach. The first portion of the stomach is called the cardiac layer, and essentially there's a very sharp transition between the esophagus and the stomach, and this is what it looks like. Stratified squamous epithelium here meets very suddenly simple columnar epithelium of the stomach, cells that are a single layer deep, very tall columnar cells right there. So the stomach has this very typical single layer of tall columnar cells, whereas the esophagus has a lot of these cells stacked on top of each other to resist abrasion. One reason this can be a problem is if the acidic contents of the stomach are frequently thrown up into the esophagus, in the case of gastroesophageal reflux disease or GERD, or in the case of bulimia. The esophagus is not meant to handle that prolonged acidity, and you can wind up with it actually undergoing metaplasia. You can have the simple columnar epithelium of the stomach start to be expressed in the lower part of the esophagus. That's called metaplasia, when you have a shift in the epithelial lining of an area. Now that's a problem because it causes inflammation, irritation of the area, and can actually lead to esophageal cancer, adenocarcinoma in that area. So Barrett's esophagus is that transition of lower esophagus to become more stomach-like, and it is a pathologic process. Now, when you picture the abdominal organs, you probably think of something like this. You've got the liver on the right, you've got the stomach on the left, spleens tucked away back there, and a lot of intestines, small intestine and the large intestine around the periphery. But there's an organ very few of us have heard about, and normally I'd ask you guys to raise your hands, but we don't have a big group, so just let me know if you've ever heard of the greater omentum. The greater omentum is this sheet of tissue that's hanging down from the greater curvature of the stomach, rolls down like an apron, and that's actually what omentum means, and then its underside attaches to the transverse colon. When I first took anatomy and I was in the gross lab, I didn't know that the greater omentum was a thing. And I got into the abdomen, and all I saw was this sheet of kind of adipose tissue and connective tissue, and I kind of lost it. And I was like, oh, everything's fat. I can't take it anymore. There's just fat everywhere. There's not even any organs. It's just fat. And my advisor, the gross anatomy instructor, came over and wordlessly picked up the omentum, flipped it up, and there were organs underneath, and I felt duly chastised and humbled. And so, just be aware, if you're doing an abdominal procedure, the omentum is a thing, and it's going to hang out in this area, and you may have to move it to gain access to some of the structures in the abdomen. It also responds to inflammation of the area and can actually form adhesions to wall off inflamed areas of the abdomen. So it's not uncommon to have to kind of shim it off of the abdominal wall when it's responded to inflammation or a post-surgical scar and is fused with the abdominal wall and adhered to it. Now, when we talk about the stomach, it has 4 separate regions, and the first, just after we leave the esophagus, is called the cardia, or the cardiac region of the stomach, and it creates a lot of mucus. Then we have the fundus, the dome, which is continuous with the body, and then the pyloric region, which also creates a lot of mucus. Now, these mucus-creating areas are very important. The whole stomach creates mucus. It's just a little more specialized in the cardia and pylorus to do just that. But the mucus that's created here helps to block gastric contents from coming up into the esophagus and also to keep the cells of the stomach themselves safe. If it weren't for that gastric mucus, the hydrochloric acid that our cells create in the stomach would actually erode our own cells. It's the mucus that stops that from happening. And likewise down here in the final part of the stomach, or the pyloric region, we have mucus to protect these cells, but also to help block just inadvertent release of stomach contents into the small intestine. Now, the cells in there will be discussed shortly, but let's talk about the wall of the stomach first. Unlike the rest of the generic gut tube, it actually has 3 layers. And the stomach is in a weird kind of shape where it's ballooned out to the left side and a bit inferiorly, creating a greater curvature. And then on its right or superior side, we have a lesser curvature stretching between the esophagus along the lesser curvature of the stomach to reach the duodenum there. Now, the outer layer of the stomach is somewhat discontinuous because it balloons out so much, but it's mostly longitudinal. And then the middle layer is more circular. We can see it's been shown here. But then there's a diffuse oblique layer that's even deep to that. So the stomach has 3 layers, and these fibers are laid out in such a way that it allows the stomach to really move in a pretty sophisticated way and grind up food, mechanically expose it to the acid that it's creating. Jumped ahead a little too far again. The circular layer gets especially thick in the pyloric region and forms the pyloric sphincter. Now, the pyloric sphincter is typically contracted, so it keeps the stomach and duodenum from contacting each other directly, and the pyloric sphincter will occasionally release to allow just a little bit of stomach contents to enter the duodenum and pass along before tightening again and then repeating the cycle, so that stomach contents should move into the duodenum very gradually. Now, the stomach, its microstructure, allows it to do its job. Cells in the epithelium release a lot of mucus, and it's only really in the body and the fundus that we have other cells present that release the hydrochloric acid that makes the stomach have its low pH environment. So right here, all these purple staining cells are mucus secreting cells lining the stomach. It's a simple columnar epithelium, and what we've got are these cells lined up around what are called gastric pits. And the epithelium of the stomach actually dives very, very far down into its mucosa. The epithelial lining is just this purple lining on the outside. Here's the muscularis mucosae, and everything else here is lamina propria, but it's got some deep pits coming all the way down and back up to connect with the surface lumen. Now, inside these pits, we have 2 unique cells that are only in the stomach. The parietal cells, these pink fried egg looking guys, they are the ones that release the hydrochloric acid and lower the pH of the stomach. They also create a protein called intrinsic factor, which helps us absorb B12. That's going to be very important when we're making blood. What's interesting is the cells that release the intrinsic factor are here in the stomach, but it's not absorbed with the B12 until we get to the ileum, the last part of the small intestine. Now, nearby we also have these little paler blue cells. These are chief cells, and they release some digestive enzymes that are going to help us break down proteins and fats. So we've got pepsin, renin, and lipase here for fats. Other parts of the digestive tract do that as well, but we get that started here in the stomach. And some problems can occur when the stomach's structure and function get a little out of whack. Now, if we have a thinning of the mucus layer that protects the stomach, the low pH environment will attack the cells of the stomach itself and go into its wall. This can create gastric ulcers, also known as peptic ulcers, and this can happen for a few reasons. You can have too much acid secretion, maybe due to too much parasympathetic stimulation. NSAIDs thin out the mucus layer as well, so if you take aspirin, ibuprofen, things like that over a prolonged period of time, it can actually lead to some problems with ulcers. But a relatively recent discovery, not recent, super recent, but within the last 30-40 years, is that it's often a bacterial infection that causes this. We have a bacteria called Helicobacter pylori that is able to survive, not wonderfully, but survive in the acidic environment of the stomach, and it burrows into the mucus layer to attack the epithelial cells of the stomach and worm its way in between them to get deeper. So it's going to create an environment where it thins the mucus and attacks the cell lining, which leaves us open to further autodigestion from that acid. So that's it for the stomach. We're now going to move on to the small intestine. Now, the small intestine wants everything to be normal so it can absorb nutrients. So it has to take that low pH bolus of food that's being released by the pyloric sphincter and raise its pH back to a more biologic level. It's got to add bile salts and digestive enzymes from the other organs, so bile salts from the liver and gallbladder, and digestive enzymes from the pancreas, and it's also going to absorb nutrients. Our small intestine is where the majority of nutrient absorption is going to happen. And we have three regions: the duodenum, the jejunum, and the ileum. Now, the duodenum is a C-shaped ring of small intestine leading from the stomach and ends up here at a little flexure that goes to the jejunum. The jejunum is about 2/5 of the small intestine's length, and it tends to be more on the upper left quadrant. And as we move from the jejunum, we enter the ileum, which makes up the remaining 3/5 of the small intestine, and it tends to be more on the lower left quadrant. Now, those are tendencies, not absolute locations, but the ileum tends to be more lower and to the left, to the right, and then we have the ileum entering the large intestine. So let's talk about how the small intestine does its job. First thing is it needs to be able to absorb nutrients, and to absorb, you want surface area, and the intestines goes crazy with creating surface area for absorption to happen. Macroscopically, we have kind of visually distinct folds in the wall of the small intestine called circular folds, or plicae circularis. We can see those right there. And these are fairly large. They've got a core of submucosa anchoring everything there. And these kind of extensions of lamina propria and epithelium up off of these folds, these are called villi. Now, villi are microscopic. You have to look at them. You have to look at them microscopically to actually pick them out. They give the lining of the intestines kind of a velvety appearance, though, so their presence can be appreciated with the naked eye, but to really see them in detail, you need a microscope. These are going to create more surface areas. They stretch off the lumen and the plicae circularis. They've got a lining of epithelium, simple columnar epithelium, and at their core, they've got lamina propria and a small hollow area called a lacteal. That's actually where lymphatic fluid will drain and dietary fats travel in that lacteal. Now, that's a pretty good increase in surface area, but we can get even better when we look at the surface of these cells and we really look at the deep microstructure of them. We see microvilli. And these are surface extensions of each individual simple columnar cell that massively increase the surface area on the lining the lumen there. So all of these little bumps are in contact with the lumen and allow the cells to absorb nutrients effectively. Now, when we have long-term inflammation or irritation in this area, these villi, which look relatively normal here, stretching up off the surface, can become blunted, and we have something that looks like this. This tends to be what happens in things like celiac disease, where we have not an autoimmune, but we have an immune reaction to some dietary products like glutens or other things that people might be sensitive to. This long-term loss of villi equals a long-term loss of surface area, less ability to absorb, and therefore less nutrition coming into the body in the first place. Now, the duodenum is the first part of the small intestine, and it's got all those typical features. It's got plicae circularis, microvilli, all that jazz. But it also has, in the submucosa, a huge number of duodenal glands, also known as Brunner glands. And these are pumping out bicarbonate. Bicarbonate is a fairly basic solution, and that basic solution is going to neutralize the acidic contents coming from the stomach. So it's going to raise the pH, hopefully back to the normal biologic level, so that by the time we get further down the small intestine, we're going to have normal biological pH. Now, it takes a little time for that to happen, and the duodenum tends to have slightly lower pH than the rest of the small intestine, but not quite as low as it was in the stomach. So, the pyloric region ends here. Here's the pyloric sphincter. The duodenum gets its name from being 12 fingers in breadth, and duodenum means 12 fingers long. So, it has 4 sections. The superior portion, or the first section, receives the bolus of food from the stomach. The descending or second part carries that further along, raises the pH a bit, but it also receives the common bile duct from the gallbladder and liver, as well as the main pancreatic duct, and sometimes an accessory pancreatic duct from the pancreas. So bile salts for mobilizing fats, and digestive proteins for digestive enzymes for proteins and carbs and other fats are released in there as well. The inferior portion of the duodenum is here. It's the third part, and the superior mesenteric artery and vein pass anterior to it. That can be important when it gets compressed by those vessels. The fourth or ascending portion travels up, and it's actually anchored to the body wall by a small ligament or sometimes muscle that's not visible here, but it's behind the pancreas. And after that, it takes a little bit of a U-turn, and we've got the jejunum, the second part of the small intestine. Here's that ligament. It's known as the suspensory muscle or suspensory ligament, also known as the muscle or ligament of Treitz, and it's a fairly important surgical landmark, and it really kind of denotes where the duodenum stops and the jejunum begins. And the duodenum does not have a mesentery. It's not suspended off the body wall hanging out in the peritoneal cavity. Instead, it's stuck to the back body wall. But the jejunum is stretched off the posterior body wall and has some mobility for that reason. The mesentery is the structure that anchors it to the body wall, and I'll have a whole little tutorial about that in just a bit. But essentially, it marks the transition from that retroperitoneal, no mesentery duodenum to an intraperitoneal, does have a mesentery, jejunum. And here's a little bit of what this looks like in context. If we flip the greater omentum and transverse colon up out of the way, we can see the fourth part of the duodenum making that turn, becoming the jejunum, and here's the mesentery that's anchoring it to the body wall, but gives it a degree of flexibility and mobility within the abdominal cavity. Now, if we lift up the greater omentum and the transverse colon here, we can see the mass of intestines right here. The small intestine is there. Mostly upper left quadrant is jejunum, mostly lower right is ileum. But there's no clear visual distinction for where the jejunum stops and the ileum starts, just looking at it grossly. There are some microscopic differences, and there are some differences in their blood supply, but it's not a simple thing to tell when one starts and one stops. Vascularly, they have a slightly different layout in that the blood vessels that supply them form loops. These are called arcades. There are some arcades, here's some more, and those arcades give off straight vessels or vasa recta. And the jejunum tends to have fairly simple arcades and long vasa recta, whereas the ileum has very interconnected, complex arcades and very short vasa recta. The ileum also has lymphatic accumulations in its submucosa called Peyer's patches that are lacking in the jejunum. So the jejunum is essentially very much the generic gut tube, the generic small intestine. It's got muscularis externa, serosa here, muscularis externa, submucosa, lamina propria, muscularis mucosae, and epithelium sticking up into the lumen on individual villi. At the core of each villus is a lacteal. We can see that right here for fats and lymphatic fluid. And that's pretty much it with the jejunum. No special features. So the duodenum had the Brunner's glands or the duodenal glands. The jejunum just has all the normal stuff. Now, I mentioned those lacteals. They're important because fats tend to drain into those lacteals, and they are going to carry lymphatic fluid as well. And then they drain into the lymphatic vessels from the gut. They're called lacteals because it was noted in animals, throughout history, that young animals that were still drinking milk, or even animals that had a high-fat diet, would have this whitish kind of a fluid in their mesentery, and they thought it looked like milk, so they referred to these lacteals as the structures that were involved. Essentially, fats drain into the lymphatics through those lacteals and then move through the mesentery that way. The reason that's important is that when we have carbohydrates and proteins absorbed, I don't know why that did that, when we have carbohydrates and proteins absorbed, they are going to wind up in the blood vessels coming from the gut and going to the liver, the portal hepatic blood vessels. That means the liver gets to get a look at the proteins and carbs and other things that are there and detoxify any problems that are in there. Any toxins that we've taken in, the liver gets to view. But if it's going to be fat soluble, it moves in the lymphatic system and bypasses the liver until the lymph gets to the cisterna chyli, thoracic duct, left subclavian vein, enters the bloodstream, and only then, if that blood makes it into the liver, does the liver get a shot at actually detoxifying any fat-soluble toxins or poisons that were taken in. So just be aware that fat is absorbed through those lacteals and bypasses the liver. Now, the ileum looks pretty much exactly like the jejunum from the microscopic level, except for the fact that we've got these huge accumulations of lymphatic tissue called Peyer's patches, or these ileal lymphatic accumulations right here in the submucosa and even extending out into the lamina propria there. So these lymphatic nodules are constantly sampling the lumen of the gut. There are little cells that are in there called M cells that actually help them take a look at what's going on in the lumen and respond accordingly to keep the gut normoflora intact and to take out any pathogens that have made it that far down the digestive tract. The ileum is also the place where B12, vitamin B12, is absorbed if it was bound to intrinsic factor. So we need the stomach to have the parietal cells need to release intrinsic factor to bind B12, and then that complex gets absorbed in the ileum. So no matter what we do to the gut, we have to keep enough stomach and enough ileum intact so that B12 can be absorbed. Because if we don't take care of that, we can wind up with B12 deficiency, which causes pernicious anemia. Now, I didn't know what that meant when I first started doing this course, so I decided to look it up, and pernicious basically means it's something that's really nasty. It's injurious, it's kind of insidious, it kind of works its way in, and it's very nasty. And I usually try to find some celebrity who embodies all that, and I really haven't found anyone better so far than Honey Boo Boo's mama right there. She just gives me the willies. So think of something really, really nasty and injurious, and there you go. Now, the ileum ends when it empties into the first part of the large intestine. This is called the cecum. Now, there's not really a true sphincter here. There's no circular fibers that wrap around and prevent the bolus from leaving the ileum and moving into the cecum, but there is a little bit of a compression there. So it's not super easy, and as it relaxes, the bolus can move more easily or not, but there's nothing ever fully stopping it from moving in. It can form what's called a papillary form, or it bulges out a little bit, or it can have a more slit-like appearance, or lip-like, or labial form there as well. Now let's take a note that the cecum is a blind pouch, but there's also another blind pouch off this blind pouch. And that is the opening of the vermiform appendix. So the appendix is part of the large intestine, just kind of barely, and it releases mucus, has some lymphatic fluid in as well, so it wants to be able to release this content into the cecum. And if it gets blocked, that can be something that causes appendicitis. So inflammation of it, blockage of its drainage can all cause inflammation and swelling of the appendix, which then results in lower right quadrant pain that becomes more and more well localized, and the appendix can actually burst if it's not relieved and able to actually release its contents. So that's going to release into the cecum. The ileum releases the bolus of food at the ileocecal valve, and then the majority of this bolus moves up the ascending colon. Now the colon, the colon or large intestine is not about absorbing nutrients. It's about absorbing water. So that's one of the major things that part of the digestive tract is going to do. So let's move a little further up. Before we do, this is a common site for a problem that tends to affect children under the age of 2, but can affect anyone. One problem that can occur in this area, as well as other parts of the GI tract as well, is when we have the intestine, and this is a little bit difficult to visualize, but bear with me, peristalse itself into its own lumen. It's like a glove being pulled off. As you pull a glove off, it covers your hand in 2 places, and the gut can actually wind up pulling itself through peristaltic motion into its own lumen. So think about the ileum peristalsing. Instead of moving stuff along, it actually kind of glides along its own surface and can pull itself into the cecum. This is called intussusception. It's a medical emergency, and it tends to affect children under the age of 2. But I really want you to stress the typically in kind of what I just said. It typically affects people of that age, but it can occur at other times, and it's one of the things that should be on your differential list for anyone, especially a child who has severe abdominal pain, vomiting, and so forth. So this is intussusception. It can actually be detected fairly readily with the ultrasound. It gives you like a bullseye appearance as you look at it, and you can see multiple layers of the gut inside itself. The ileocecal valve is a common place for it, but it can occur anywhere along the GI tract in the small intestine in particular. I struggled for a while to kind of keep track of this word. It's a little bit of a strange word, but I think I've got something to help you guys out. All right, back to the large intestine. So the large intestine, as I mentioned, is going to be all about resorbing water from the bolus of food and turning it from watery to more solid fecal matter that gets passed out through the rectum. So we're absorbing electrolytes and water, and it's much shorter than the small intestine, but it's much broader and has a much wider lumen typically. So the portions of the colon are the cecum, with its appendix sticking off its inferior side, the ascending colon, the transverse colon, the descending colon, sigmoid colon, the rectum, and then the rectum meets the outside anal canal at the anorectal junction. So let's run through those different areas. First off, the appendix is a very clinically important organ. Even though it's considered to be vestigial by most, it is actually clinically important because if it gets blocked, it's a blind pouch. It has nowhere to go. So it can balloon outward, kind of like a party balloon, in that it just stretches outward. And that inflamed, irritated appendix causes visceral pain, not only to itself, but to other tissues nearby that it inflames. So you're going to have loose, not indistinct, poorly localized pain of the abdomen when you have appendicitis, but as that the appendix starts contacting the parietal peritoneum, which is going to be innervated by intercostal nerves, that's going to cause well-localized pain in the right lower quadrant typically. So if you have somebody with progressively worsening abdominal pain that gets more and more distinct, more and more well-localized, and finally comes to rest in the lower right quadrant at a place between the umbilicus and the anterior superior iliac spine, that's called McBurney's point, and that is textbook appendicitis. So the appendix can balloon out due to infection, due to blockage, so that its mucosa can't have mucus released from it. And if it ruptures, it will cause widespread peritonitis potentially as fecal material and other stuff works its way throughout the peritoneal cavity. Should also mention that hardened bits of fecal material can actually block the opening of the appendix. That's called a fecalith, or, forgive me for it, but a shitstone is how that translates. So blockage of the appendix by a fecalith can also be a cause. The appendix has also been shown recently to maybe have some function in humans. It's not fully vestigial because during severe diarrheal diseases like cholera, things like that, some of the bacterial normoflora are actually protected in the appendix, and after the diarrheal disease has passed, those normal helpful bacteria can recolonize the rest of the colon much quicker if the appendix is there as a reservoir for them. So there you go. The ileum has a mesentery, the ascending colon does not have a mesentery, and the appendix typically does have a small mesenterial mesoappendix containing its blood supply coming off the ileocecal artery, the ileocolic artery here. More on those blood vessels in a little bit. Now, typically, the appendix has this nice little mesentery, and it should be visible, especially if it's enlarged, hanging out on the underside of the cecum. But the appendix doesn't always do what we'd like it to do. So right there is the typical, intraperitoneal appendix. But sometimes it winds up folded on the posterior wall of the cecum, and you actually have to lift it up to get access to that area behind it. And it can be laid out on the posterior side of the cecum and actually extend fairly high up into the area of the ascending colon as it does so. Now, one thing you may have spotted on all these illustrations is that there are longitudinal bands covering the large intestine. These are called tinea coli, and they're actually the outer longitudinal smooth muscle layer for the colon. They don't spread out evenly. Instead, they kind of focus themselves into 3 tough bands of longitudinal smooth muscle. And if you're ever having trouble finding the appendix, you follow the tinea coli. If you can find one, you follow it, and they come together. All 3 of these converge at the base of the appendix. So it's one way you can invariably find the base of the appendix no matter where it's located in the vicinity of the cecum. So as I mentioned before, abdominal pain caused by appendicitis tends to start diffuse and then localize itself to here, McBurney's point between the ASIS and the umbilicus. Now that's if you've got a typical appendix located in the typical spot. However, the appendix and the cecum can be located in a variety of places. So if you have somebody who has diffuse pain of the abdomen become more and more localized, but instead of here at McBurney's point, it's over here, or over here, or over here, appendicitis is not 100% off your list of differentials until proven otherwise. Now, the cecum is right here in the right lower quadrant, so let's follow the rest of the colon through its course. The ascending colon moves from right lower quadrant to right upper quadrant, and it turns into the transverse colon, which has a mesentery. It's hanging off the body wall here, and it does that at the right colic flexure, also known as the hepatic flexure because the liver is just above it. The transverse colon moves from right to left, but because it's got that mesentery, it can actually hang down a fairly significant degree when it's just laying out in the abdomen. It moves over here to the left upper quadrant and becomes the descending colon, and that is called the left colic flexure, where that transition happens, also known as the splenic flexure, because surprise, surprise, the spleen is nearby as well. Descending colon moves from left upper to left lower quadrant, and then we get the sigmoid colon. Sigmoid colon also has a mesentery, and it kind of loops its way around this area here. Sigmoid because it's kind of S-shaped, but tends to be fairly well localized in the left lower quadrant. The sigmoid colon then dives deep and posteriorly into the pelvis to become the rectum. Rectum has no mesentery, and it's going to then move down to join the anus at the anorectal juncture and release the fecal contents to the outside. When we look at the large intestine microscopically, one thing you can really note are those tinea coli, those clusters of longitudinal smooth muscle. So instead of an even longitudinal layer like we saw in the small intestine, they tend to bunch up in those layers. And what's left on most of the rest of the colon is going to be circular smooth muscle. So that allows the colon to create these little cells inside right there, and they're basically going to accordion a little bit to move fecal material along, and peristalsis, the circular motion, progresses down. So peristalsis happens, but in a slightly different way. Those little cavities that are formed in the process of doing that are visible during an endoscopic exam or a sigmoidoscopy. You can generally see them right in there, and you can see the tinea coli stretching. They're actually reflected on the inside, and you can actually see them, or at least the effect of them, on the inside. Now, these individual little pockets that are formed in the process are called haustra. So you've got haustra there, and one thing I want to draw attention to in this picture is that on the outside of the colon we have a variable amount of fat hanging off one of the tinea coli. Now, people with larger BMI will tend to have more fat in more places, and this is one of the places that it's going to accumulate. Despite their insignificance, these little outpouchings of fat can actually mimic appendicitis if they get twisted along their pedicle, or where they're hanging off the intestine, because that'll shut off their blood supply, and it'll actually make them they'll have visceral pain that can be referred as a result, and depending on where they're located, it can actually mimic the pain of appendicitis, and some people have had surgeries to take care of an inflamed appendix, which turned out to be just fine, but one of these little fat pedicles turned out to be the problem. So that's one small little twist related to them you might want to be aware of. So what other things can go wrong in the colon? Well, you kind of have two different appearances in a sense. One gets punched out and one gets grown in. The punched out part of the colon that we can sometimes see are called diverticula, and these are actually weak spots in the wall of the intestine, and its mucosa pushes out, sometimes between the submucosa and even outside the muscularis externa a bit. So these little holes are areas that can catch fecolus, those little stones of fecal material. They can become inflamed, serve as a source of infection, and diverticulitis is going to be inflammation of these diverticula. Tends to be associated with poor fiber diets, straining when defecating, things of that nature. On the opposite side, we can have polyps. These are generally starting out as benign overgrowths of the mucosa, but because they are proliferating a little more out of control than they should be, they have been known to transfer to actual cancer and start proliferating completely out of control. So they're often removed if they are spotted during a scope. So as we get closer and closer to the anus, the longitudinal bands on the outside of the colon, the tinea coli, fan back out and cover the outside surface, and they mostly make an anterior and posterior layer on the rectum. Now, the rectum's main job is to actually hold the fecal material until we're ready to defecate, and so it's smooth muscle, and when the rectum distends a certain amount, the stretch that smooth muscle feels is going to trigger a contraction, and that gives us the sense of urgency, gotta go poo. And in addition to that, we have a smooth muscle sphincter at the base of the rectum, which is going to relax as well. Now, thankfully, everything below there, the external anal sphincter and this muscle here, we'll see in a minute, called the levator ani, are skeletal muscle. That means we have some degree of control over exactly when defecation actually happens, even if our rectum is contracting and our internal anal sphincter is relaxing. So here we can see the sigmoid colon transitioning into the rectum. You can see the tinea coli fanning out onto its surface there underneath the peritoneum. And note that we've got some folds on the inside. We'll see those a little bit better in a moment. But those are transverse rectal folds. They help the fecal material get kind of spiraled and shunted down towards the anal opening rather than just accumulating a big pouch here and distending the rectum. There's the internal anal sphincter, which is continuation of the smooth muscle circular layer on the inside of the rectum, and that meets with and blends with the external anal sphincter, which is actually skeletal muscle. So different type of muscle, different innervation, although they're very close to each other. The anus is right there, and one thing to note about the anus is that it actually forms separately from the rectum. It forms by kind of pushing in from the outside, and it joins the gut tube, which is growing down and kind of folding in from within, and the two actually meet at a membrane which ruptures. We'll talk more about that in the development talk. Here's a little bit more complete view of the whole process. We've got the sigmoid colon transitioning to the rectum at that little rectosigmoid junction, a little bit of a turn right there, and we got three transverse rectal folds that just help keep the fecal material moving smoothly down the rectum even as it expands. And I don't know if this is someone's name or if they just didn't care for the city of Houston, but these do have an eponym, and it is the inferior, middle, and superior transverse rectal folds of Houston. Now, the levator ani is some skeletal muscle that's coming in and fusing with the outermost layer of the rectum. And on the inside, we have some specific landmarks that are important. We've got these raised ridges of mucosa called the anal columns of Morgagni, and then we've got the anal canal. Now, one thing I want you to be aware of is that where the anus stops and starts depends on what sort of practitioner you're talking about. Some people say the anus is going to be from here up to the base of the columns. Other people say it's all the way to the top of the columns. Still other people say it should only be here to this little line, marking where the invagination of the anus met the gut tube that was growing from within. We're not going to worry about it for this course. This whole area we will just refer to as the anus. Just be aware, when I talk about it, it's the area that grew in from outside and has a separate innervation and blood supply, and the area above is the rectum. The anocutaneous line marks that actual embryologic place where the two met, and there had been a little membrane present which ruptured. And a little close-in view now, you can see the longitudinal smooth muscle of the rectum and the inner circular layer. The inner circular layer just expands out, gets very large to create the internal anal sphincter. It is tonically contracted most of the time, but when defecation starts, that smooth muscle will actually relax to allow the fecal material to pass. The levator ani is skeletal muscle that fuses with this longitudinal smooth muscle layer, and then we transition essentially into the various parts of the external anal sphincter. Deep part, superficial part, and then the subcutaneous part has these little extensions going out to the skin, and that's what makes the typical sort of puckered, wrinkly appearance of the anus. And that's actually kind of important when you're looking at somebody who might have a spinal injury. If the anus is acontractile or atonal, it'll look a little bit different. The fact that this is innervated and looks the way it does gives you some sense that the person may or may not have a spinal injury in their sacral region. Now, right here, let's take a closer look at those anal columns, because some kind of bad stuff can happen with them. Essentially, the columns are stretching up here, and there's a little webbing between them and a little pouch behind that webbing. The little pouch there is going to be held in place by the anal valve, and that pouch has the name anal sinus. The problem we have with this area is that if we have inflammation, prolonged fecal material exposure in here, we can actually wind up with these sinuses getting eroded and having the inflammation kind of burrow into the surrounding anal musculature and even out to the skin. That's called an anal fistula when that happens. The anocutaneous line, once again, marks where the invagination of the embryonic anus met the kind of growing down or growing inward portion of the gut tube. And one thing that's important about the fact that we have two different embryologic origins for these guys is that we've got a unique blood supply, blood drainage, and innervation below that line, and a separate innervation, arterial, and venous supply above that line. So in the vicinity of the columns, we actually, and within the columns themselves, actually, we have these internal rectal venous plexi. These are venous plexuses. They're draining this area. And we have on the outside external rectal venous plexus. These are draining to the, should we say, the caval veins. They're going to wind up going to the iliac veins and getting to the inferior vena cava, whereas these more superior rectal venous plexi are going to wind up going to the hepatic portal system. So if we have portal hypertension, we can wind up with some of the veins here distending and creating internal hemorrhoids, which tend to be painless yet can enlarge pretty significantly. And if we have irritation and inflammation or damage to this external anal area, we can wind up with inflammation of these external rectal venous plexus vessels causing external hemorrhoids. And these do not have to be very large at all to cause significant amounts of itching and pain, and people will complain about those pretty readily. So at the anal-rectal junction, we noted that there was a stark difference in the innervation and the blood supply. There's also a stark difference in the mucosa. We have simple columnar epithelium in the distal rectum, and boom, transitions to stratified squamous epithelium at the anus itself. So it's a little bit of a reverse of what we saw at the gastroesophageal junction. So that change is pretty similar to what we saw above, except now we're transitioning back to stratified squamous epithelium because we're on the outside of the body and it needs to be able to resist abrasion, dehydration, and things like that. All right, we've covered the gut tube. Now let's move on to some of the other organs in the abdominal cavity, and the first one is the liver. So the liver is one of the largest organs we have. If you count skin, skin's larger, but the liver is the largest internal organs, and it does just so many ridiculous things. It creates a lot of the plasma proteins that keep our blood at the proper osmotic level, so albumin, things like that. Stores and distributes vitamins, glucose, iron. It's going to screen blood coming to it from the hepatic portal veins, so making sure that substances coming in from our gut are detoxified, and then making sure that the kidneys can deal with them if need be. It creates a lot of the clotting factors that are circulating throughout the body, and bile. It makes bile, which a lot of people associate with the gallbladder, but the gallbladder really just stores what the liver gives it to hold on to. And I mentioned iron briefly, but breakdown of red blood cells in the spleen releases iron in heme groups that then go to the liver, and that's where they're dealt with. Heme groups for making bile, and iron will be stored in the hepatocytes, and if that gets a little bit overabundant, you can have iron storage problems leading to things like hemochromatosis that actually damage the liver because of too much iron. We'll talk about that in a little bit as well. But now let's talk about the liver and grossly where it's located. Most of the liver is in the upper right quadrant of the abdomen, and if we elevate it, we can see that it covers a significant portion of the stomach, the duodenum. The right kidney is located posterior to the liver, and the spleen usually doesn't touch it. This is a little bit grandiose. I don't think the liver is quite that big usually, but the spleen will be over on the left, liver taking up most of the right. The liver has a huge right lobe and then a left lobe and two other smaller lobes we'll see in a little more detail when we have a better picture. The gallbladder is almost always on its inferior surface, poking out on its anterior margin there just a little bit. If we pull the liver away from the body, and it's basically been pulled off and flipped over to here, we can see that the peritoneum, the parietal peritoneum lining the entire abdominal cavity, reflects onto the liver, creating its visceral peritoneum. Now there's a small area where that reflection occurs that has the liver in direct contact with the posterior body wall, and that's including some of the inferior vena cava, some of the diaphragm right here, and so we've got that reflection of the parietal peritoneum onto the liver. This creates what's known as the coronal ligament of the liver, and it comes to a point on the right and the left. And these are called the triangular ligaments of the liver, and they're landmarks when you're doing procedures in the area. So just know that the triangular ligaments are just the far left and right extensions of the parietal peritoneum reflecting onto the liver right there. Now, most of what we see when we look at the liver from its anatomical view anteriorly is the right lobe. We've got a lot of contact with the rib cage on the right side. Then we have a connection to the anterior body wall called the falciform ligament. And then we see the left lobe of the liver, typically much smaller, going off to the left there. There's that left triangular ligament holding it to the diaphragm, and the right triangular ligament over on this side. Now, I want you to note that the round ligament of the liver is this very tough cord that's actually inside the falciform ligament. If you think back to transitional circulation from the placental circulation to mature breathing, this is what's left of the umbilical vein traveling from the umbilicus through the liver, and there's actually a little fibrous pathway in the liver that got blocked up. That's going to be that ductus venosus that becomes the ligamentum venosum inside the liver. Gallbladder just on the inferior side of the right lobe there, as we'd expect. When we flip it and look at its underside, we can see the actual 4 lobes. The smaller left lobe, right there, and we can see between the falciform ligament and the ligamentum venosum and the inferior vena cava the caudate lobe. It's more caudal, it's a little further back, and then between the falciform ligament and the gallbladder we have the quadrate lobe, kind of quadrangular shaped, hence the name, and there's that ligamentum venosum, that little fibrous cord passing through the liver, and the falciform ligament containing the round ligament of the liver right there. Inferior vena cava, gallbladder, and then the rest of the liver, and the majority of it, is this left lobe. It's absolutely huge. So at this point we've accounted for all the lobes of the liver and its structures, but I want you to notice that all the vessels coming and going to the liver here, accompanied by the bile ducts, are at this one spot called the porta hepatis. And that's where all the blood coming to the liver and the bile leaving the liver are going to exit. Inside the inferior vena cava are some hidden veins that are draining blood from the liver into the IVC. But this is called the porta hepatis, or the portal triad, and it's located right here. We've got the right kidney in contact with the right lobe of the kidney there. There's also an impression for the right colic flexure or hepatic flexure. Over on this side, the stomach's fundus pokes up into the left lobe, so it's going to be present there. And there's that portal triad, or portal hepatis, I mentioned right there. Now, the portal triad is important because all the blood going to the liver, both oxygenated blood to supply it, deoxygenated blood from the gut tube in the hepatic portal vein, are coming in this way, and the essential drainage of bile from the liver happens in this area too, but that's going the opposite direction. It's descending from that portal triad down to reach the duodenum. If you ever have to stop blood flow from the liver, if you have somebody with a hepatic laceration and you're in the operative field and you just have a hard time seeing where it is because of the hemorrhage from the liver, you can actually try to get your finger behind this ligament connecting the liver to the duodenum and pinch that portal triad to see if you can staunch the blood flow briefly to identify where the laceration is. Now, this sheet of tissue, this is called the hepatoduodenal ligament, and it contains the portal triad, and it's continuous with this hepatogastric ligament connecting the underside of the liver to the stomach. These two together are known as the lesser omentum. So greater omentum's hanging off the curvature of the stomach here, greater curvature, and then the lesser omentum is going to the lesser curvature of the stomach. And it's two parts of the hepatogastric and the hepatoduodenal ligament. Looking inside the liver, we can see the cells that let it do what it does. These are hepatocytes, and nothing really looks like the liver. This is pretty unique. Now, each one of these cells, making up these darker purple kind of cords, are going to be hepatocytes. So we have hepatocytes all throughout the liver in these loose accumulations, and there's spaces in between them for blood to flow through. These are called sinusoids, hepatic sinusoids. They have a discontinuous surface so that fluid in the blood can just spill out of these open vessels and surround and interact very intensively with the hepatocytes that are there and allow their microvilli to access toxins, access iron, access other stuff that's coming to it through the bloodstream. The liver has to have a great deal of blood flow coming through it in an uninterrupted, unimpeded way. And if we had a lot of connective tissue in the area, it would block that flow. So instead of large type 1 collagen fibers that take up a lot of room, like a tendon or an aponeurosis, we instead have type 3 collagen, which is known as reticular fibers. And they're at the core of these hepatocytes. So if you think of type 1 collagen as a big steel girder, think of type 3 collagen as a high tensile wire. It takes up less space. It's maybe not as strong, but it's pretty strong. And it's strong enough for these hepatocytes to kind of hang themselves on as a scaffolding and stay supported. Here's what the electron micrograph of this area looks like. Here's a fenestrated, or actually should be labeled a sinusoidal capillary, traveling through the liver, and these are the hepatocytes on either side of it. And these openings of these sinusoidal capillaries actually spill into a space that's called the perisinusoidal space, and that's where these microvilli of the hepatocytes are actually able to interact with everything traveling through the bloodstream in the liver. On the outside of the liver, we saw the hepatic artery, the portal hepatic vein, and the bile ducts traveling together as the portal triad. And what's interesting about that is those structures stick together through macroscopic and microscopic levels of the liver. If you take a look at the vasculature of the liver at the microscopic level, you still see one of the portal veins right here. You still have a branch of the portal vein carrying blood from the gut tube to be screened by, detoxified by, modified by the liver. You have a hepatic artery, a smaller structure, but it's bringing oxygenated blood to the liver because this portal vein blood has already been through a capillary bed. It's mostly deoxygenated, so we need oxygenated blood to actually supply the cells of the liver. And we have a bile duct. We have cuboidal, taller epithelium here. That's fairly typical of glands. So we have these glandular ducts that are going to be following the portal hepatic vein and hepatic artery, but going the opposite direction to drain bile. So that's the portal triad. But there are actually 4 members of the portal triad. They were described before lymphatics were really well known. And there are actually lymph vessels, and we can see one right here, in the same basic area. So there are, in fact, 4 members of the portal triad, which slightly fills me with rage because of that, but also because I never really liked the fact that how many Three Musketeers are there? There are, in fact, 4 Three Musketeers. And yeah, before anybody decides to remind me, yeah, D'Artagnan wanted to be a musketeer, but he wasn't really one of them at the beginning. Yeah, I still don't buy it. He's like a big character, so what the hell? Why are there 4 members of the Three Musketeers? I'm still not buying it. Anyhow, the blood that's coming into the liver through the hepatic portal vein and the hepatic arteries distributes itself throughout the liver, spills into the sinusoids. It actually mixes. So the hepatic portal vein deoxygenated blood mingles with the oxygenated blood coming from the hepatic arteries, travels to the sinusoids, and it's going to drain to more central veins that are actually a little bit separate. And those are going to consolidate, join other central veins to form hepatic veins. Now, hepatic veins are going to be the ones that take all the blood from the liver and dump it back into systemic circulation into the inferior vena cava, which is located on the posterior side of the liver. Now, like the lungs, the liver actually has different segments as well that are broken down based on the blood supply. Now, I'm not going to ask you to memorize what they are, but I do want you to know that they exist and that you can have a laceration in the liver that doesn't necessarily mean you've got blood spilling into it from other segments. So if you can isolate that area that's hemorrhaging, you're not necessarily going to get hemorrhage from adjoining areas because there are connective tissue sheets separating them. So here's a view of the portal triad and the central portal veins right here. So we've got the hepatic portal vein here. We've got the bile canal right there. We've got the hepatic artery there. You could make a case that there's a lymphatic channel there. And then all that blood washes through these sinusoids, exposed to hepatocytes the whole way, being screened for toxins, having iron removed, having metabolites modified, all that good stuff, and eventually they consolidate at these central veins right here. So these central veins are where the blood drains to, and then those central veins join more and more central veins to become those large hepatic veins and get back to systemic circulation. Now, this is filtering the blood very effectively, but what's going to happen if we wind up blocking that flow? If we block the flow, and we make it harder for blood to move through these sinusoids, it's going to back up into this hepatic portal vein, which does not have the heartbeat behind it like the hepatic artery does. So we're going to wind up ballooning that structure, and we're going to wind up having blood back up into the hepatic portal veins, back up into the veins draining all the abdominal organs, and creating what's called portal hypertension. We'll deal with that in more detail when we talk about vasculature, but this is where that's going to be setting up, is when we have difficulty moving blood through the liver. And that is often caused by cirrhosis, because when we damage the liver chronically, what tends to happen is that some cells inside the liver, cells of Ito or stellate macrophages, as well as stellate cells of Ito, are going to try to repair the liver, but they don't do a great job of it. Instead of laying down reticular fibers that support these hepatocytes, they lay down type 1 collagen. They basically make a scar in the liver, and that scar is going to take up space, and it's going to make the flow of blood through these sinusoids far less direct, far less efficient, and that's going to cause long-standing portal hypertension if enough of the liver is affected by it. Another problem that can occur with the liver is a disease called hemochromatosis. It's a genetic disease affecting people primarily of Northern European ancestry, but it's having too much iron in the blood. And you can wind up having body-wide pain, kind of diffuse, poorly localized pain throughout the musculoskeletal system. Another sign of it is going to be kind of irony, rust-like staining of the skin and the forehead. We can see it on this woman here. And the liver itself is almost rust-colored because of so much iron being stored inside it. Now, the iron wants to hold on to iron as what's called hemosiderin molecules, but if there's too much, it can actually become toxic. And once you've diagnosed it, it's actually really easy to treat. You wind up just having them donate blood very frequently. Enough, if they just donate blood on a regular basis, they remove enough of that iron from their bloodstream and from their liver to take it below toxic levels. The hemosiderin granules shown here aren't overpowering the liver, not causing any toxicity, and you can get them back into a normal state. So people who have hemochromatosis actually report feeling fantastic after they donate blood. So another thing that's happening in the liver is the production of bile. And right here we can see that we've got the hepatic portal vein and the hepatic artery. Their blood is mingling as it travels through the sinusoids, going alongside the hepatocytes to reach the central vein. But if we consider that to be the main street, and the hepatocytes are the houses on the street, they all share a back alley that doesn't connect to the street, and that alley is the bile canaliculi, and that's where bile is produced, and produced from the hepatocytes and it's released into those canaliculi, which fuse to form bile ducts with their nice big cuboidal epithelium. Now, bile production never ceases. It can only slow down and speed up. And we can see a nice little view here of these bile canaliculi. And all these little bile canaliculi fuse to create larger bile ducts, and that will eventually drain to very large bile ducts. Now, bile from the left lobe, the caudate lobe, and the quadrate lobe will consolidate into these extra hepatic, or these ducts outside of the liver. The left hepatic duct, bile from the right lobe of the liver will join the right hepatic duct, and when they fuse, they create the common hepatic duct. From the common hepatic duct, it will flow into the common bile duct. There's a change of name because we've got the cystic duct here leading to the gallbladder, but we're going to ignore it for a moment. Come back to it in a little bit. So the bile will flow through the common hepatic duct, common bile duct, and down, down, down till it reaches the hepatopancreatic ampulla and is released into the duodenum to help mobilize fats. We also have a duct from the pancreas, the main pancreatic duct, traveling through the pancreas, and it actually fuses with the common bile duct at the hepatopancreatic ampulla and releases its products in the same place. But our body doesn't want pancreatic enzymes and bile released all the time. It wants to wait until we have a meal. And so, smooth muscle fibers, called the hepatopancreatic sphincter, will contract, squeeze off that opening, and then the flow of bile has to reverse, and it's going to go up the common bile duct. But we don't want it going into the common hepatic duct and up into the liver, because if that bile gets pushed back into the liver, it will actually wind up traveling into those bile canaliculi, backing up into the hepatocytes and pushing its way into the bloodstream. And that's going to cause jaundice, discoloration of the skin. And even if people have darker complexions than others, you can still detect that by looking at the sclerae, the white parts of the eye, to look for yellowish discoloration. It's called icterus. So we don't want bile backing up into the liver. So instead, it's diverted into the cystic duct, which takes the bile and puts it into the gallbladder. And the gallbladder is a nice, important organ, so just take a moment here, check out the cartoon, which is more or less accurate, and then we'll move on to talk about the gallbladder itself. The gallbladder is found on the inferior surface of the liver, and it's basically the place where we're going to have the bile become concentrated and then excreted when we have a fatty meal. So as the fat is sensed as it's entering the stomach and the duodenum, the hormones will be released from there to squeeze the gallbladder. Its muscles will constrict, and it'll propel that bile down the cystic duct, the common bile duct, into the second part of the duodenum. Now that contraction is pretty strong and can be a problem if the gallbladder is inflamed. And we have a couple different reasons the gallbladder can become inflamed. One is recurrent infections. You can actually have infections of the gallbladder. These are sometimes tied to deep clefts of the mucosa that burrow deep into the substance of the gallbladder. It's a little bit weird. It doesn't quite match the histology of the rest of the GI tract. It does have a simple columnar epithelium, but then the muscularis layer is very discontinuous and kind of not quite as architecturally sound as the GI tract has with its muscularis externa, and there's often these deep clefts or sinuses into it. These are called Roktansky-Ashov sinuses, and they're a place where bacteria can harbor and kind of recur back and cause frequent attacks on the gallbladder. Now, that's interesting to know for the fact of gallbladder dysfunction. I find it amazing because they're named for this guy, Karl Roktansky. He's a Viennese pathologist who did some amazing stuff and also had some really amazing students who even outshone his work. But he's also the namesake for Mad Max Roktansky. And if our current pseudo-post-apocalyptic situation hasn't got you too down, go watch some of the Mad Max movies for actual post-apocalyptic madness. And the guy who wrote and directed all the Mad Max movies, George Miller, is actually a physician. And there are little medical tidbits scattered throughout the Mad Max movies, like pneumothorax. At one point, Mad Max has Horner syndrome and has a blown pupil. So just be aware there's some fun stuff kind of sprinkled in there as well. Another reason that the gallbladder can have inflammation and pain associated with it is due to gallstones forming. As that bile gets dehydrated, you can actually wind up having some of these crystals precipitate out and form, sometimes significantly large gallstones, or large numbers of them. And these can tend to irritate the gallbladder's lumen. You can see how thick this gallbladder is, but they can also lodge in the cystic duct or other places and cause some pretty significant problems. Now, normally the gallbladder is going to be found on the underside or inferior surface of the liver, as we mentioned. It's going to be sitting very close to the transverse colon, and the duodenum is nearby, and the bile ducts are extending down posterior to the superior part of the duodenum, second part of the duodenum here, the descending part, and empty into its lumen right there. If the gallbladder is normal, it's not really going to cause too much trouble. But when it becomes inflamed, not only is it angry and causing visceral pain, which will be poorly defined, poorly localized pain in the upper right quadrant due to referred visceral pain, but sometimes when it gets inflamed, it can actually protrude out past the margin of the liver and actually contact the parietal peritoneum, which is innervated as part of the anterior body wall by intercostal nerves. And that is going to cause well-localized sharp pain in that area as the inflamed gallbladder irritates the parietal peritoneum. So much like how we have an appendix starting with diffuse, poorly localized pain in the lower abdomen that gradually becomes more well-localized to the right lower quadrant, the gallbladder can do the similar thing with poorly localized diffuse pain in the upper abdomen that gradually becomes better and better localized to the right upper quadrant in a single spot. Now, when these gallstones occur, they can cause inflammation, and a variety of things can happen, such as a fistula, connecting it to the transverse colon. If it wears through, you can have thickening of the gallbladder due to the gallstones, and they can lodge in the cystic duct or anywhere along the biliary tree. And if we have it lodging here in the common bile duct, no big surprise, we're going to have backup of bile into the biliary tree, possibly causing jaundice. And this little part of the illustration is just showing that you can actually have gallstones present anywhere through the biliary tree, including even intrahepatically if you have the bile salts crystallized within the liver. But I want you to pay attention to this one right here. This stone right here at the hepatopancreatic ampulla. And I want you to think about why that might be particularly bad, and we'll address it again in just a minute. Gallbladder removals are something you're almost guaranteed to see on a general surgery rotation, so you're probably going to get very familiar with part of these processes as you guys go through your education. I just want you to know that the hepatic duct and the cystic duct have a huge amount of variety associated with them. So as you're trying to identify the vessels going to the gallbladder, as well as the cystic duct leading from it, you just need to be prepared for the biliary tree to not match 100% what you expect to see from the normal textbook appearance. So just be aware that there's variation here. I'm not going to test you on these various types. And likewise, the cystic duct can sometimes join very low on the common bile duct, or very high, or wrap around one side or the other. So just know that variation exists, and you need to be ready to deal with it in a clinical setting. Now, we've got the bile draining down to the common bile duct. We've got the main pancreatic duct releasing pancreatic enzymes into the duodenum alongside, and both of them come together at a common chamber called the hepatopancreatic ampulla, or the ampulla of Vater. And there's actually a sphincter of smooth muscle surrounding it that can close it off and stop the drainage of bile salts and pancreatic enzymes into the duodenum. That's the hepatopancreatic sphincter, or the sphincter of Oddi. And these structures actually make a palpable, visible bump in the wall of the second part of the duodenum. It's the major duodenal papilla. That's where they're emptying. There's occasionally a minor duodenal papilla for a small accessory pancreatic duct as well. So let's talk about the pancreas a little bit. It's located in a bit of a deeper area. We have to reflect the stomach out of the way, cutting through the greater omentum here and lifting the stomach superiorly, and we can see that there's a space posterior to the stomach. This is called the omental bursa. It's actually separate from the rest of the peritoneal cavity, but it's connected by a small hole going just posterior to the hepatoduodenal ligament and the portal triad. And that's called the omental, well, the whole space is called the omental bursa, and this is called the omental foramen. So we just want to be aware that there's one little spot where this sac connects with the abdominal greater peritoneal sac. The pancreas is located posterior to the stomach on the posterior wall of this omental bursa, and if we have a perforated gastric tumor on the posterior side here, we can actually wind up aggravating the pancreas with stomach contents being released into this space and pushed up against the pancreas there. Here's a cross section horizontally through the body at that level, and we can see the stomach anteriorly. There's a little space there, that omental bursa, which is connected to the rest of the peritoneal cavity through this omental foramen. Gastroomental, gastropapilloic foramen, omental foramen is what we'll stick with. And then the pancreas is located on the posterior side of that omental bursa, or lesser sac. Its tail is just poking into the spleen. Its body is right here, and we can't really see the head from this view, so we'll catch that in just a minute. Right here, we've removed the stomach, the transverse colon, most of the small intestine here, and we can see that the duodenum, its superior, descending, inferior parts, make a bit of a C-shaped loop of gut, and that nestles the head of the pancreas inside that little C-shaped curve. So here's the head of the pancreas, and then the body and tail of the pancreas poking onto the spleen right there. The pancreas is an interesting organ because it's got two separate embryonic origins, and they're both originating connected to the duodenum, and that's why we sometimes have not just one but two pancreatic ducts marking those two origin sites. Now, the major pancreatic duct drains the tail, the body, a lot of the head of the pancreas, and lots of smaller ducts entering into it, and there's often a minor pancreatic duct retaining its connection to the duodenum. If that weren't good enough, the pancreas is also both an exocrine organ and an endocrine organ. Exocrine meaning it releases products into these ducts. So it's going to release products into the ducts, and these are digestive proenzymes. Proenzymes because they're not active. They're in a proenzyme state because they're going to digest fats, carbohydrates, and proteins. And what is the pancreas and everything around it made of? It's made of fats, carbohydrates, and proteins. So you don't want these enzymes just running wild and auto-lysing, auto-digesting the body. So they're released in an inactive form, and they're actually activated by acid. And so when these proenzymes are released into the duodenum, the pH there is still a bit low. The duodenum's trying to neutralize the low pH that it received from the stomach, but it hasn't quite succeeded yet. So that acidic environment activates the proenzymes, then those digestive enzymes attack the food bolus that's been moved from the stomach into the duodenum. And one other clever thing the pancreas does is it actually will release bicarbonate into its ducts, so it keeps that environment a little more basic, making it much harder for those proenzymes to become active. Now, scattered throughout the pancreas, we have the endocrine portion of the organ. These are going to be the pancreatic islands, or the islets of Langerhans. Now we have the exocrine pancreas out here. All these purplish cells are secreting and creating proenzymes, and the islet is this paler staining region right here. We're not going to get into the details of endocrinology, metabolism, and so forth, but you want to know that these islets of Langerhans are a place where our glucose metabolism is controlled to a large degree. The pancreas is going to create insulin, which will lower circulating blood glucose. So it's going to release insulin in response to heightened blood sugar, and it's going to do everything it can to lower that by moving the sugars into glycogen for storage or into triglycerides, fats for storage as well. It also releases glucagon, which does the opposite. It's going to mobilize blood glucose to get into the bloodstream in the event we have low blood sugar. So glucagon is going to be there so that we're able to move glycogen into circulating glucose and so forth. And then we have somatostatin, which is a hormone that actually helps regulate the activity of the other two. Now, there are other enzymes in the pancreas, but these are the big three for right now. And if you get a handle on what they're doing and where they're coming from in the pancreas, you should be able to follow further instruction on these when you get to endocrinology and things of that nature. So, remember back a little bit ago, I asked you to think about why a stone in this hepatopancreatic ampulla would be especially bad. Now, I want you to know that there is some variation. Usually there's a common chamber for the common bile duct and the main pancreatic duct. They don't always have that, though. Sometimes they exit separately, and sometimes they have a very significant and enlarged ampulla. But if I have a gallstone that lodges in this area, it's not only going to block the flow of bile and potentially cause jaundice, it can also block the release of pancreatic enzymes, especially if there's no minor pancreatic duct to relieve the pressure of the release of those enzymes from the pancreas. And that can lead to pancreatitis, inflammation of the pancreas. This can happen for a few reasons, but one of the biggies is if you block the release of those proenzymes, they will eventually get aggravated, the pancreas will get inflamed, and that will activate those proenzymes. They will become active, and they will start a domino effect of being active, digesting and lysing proteins and other things in the pancreas. That will activate other proenzymes. They'll become active, and this domino effect just keeps rolling. So if you can keep the inflammation under control, it will eventually get a little bit better. But the pancreas will start to autolyse if those enzymes get inappropriately activated. So, pancreatic cancer obviously is another issue. We'll discuss that when we talk about the spread of lymphatics from the abdominal pelvic organs as well. So, take a moment, deep breath. We're getting close to the end. We got one more organ to work through. So, with no further ado, let's talk about the spleen. The spleen is located in the upper left quadrant of the abdomen, and it's actually quite a bit more posterior than people tend to think. It's not right on the midline. It's protected by the ribs, but that comes with a cost. The spleen is on the left side, covered largely by the ribs, just as the liver on the right is, but both of these organs can have their thin capsules lacerated if you have a fractured rib that has a jagged end rip into it. And the capsule on these organs is very thin, and it can start bleeding very profusely because both the liver and the spleen are incredibly vascular organs. So the main thing I want you to get at the moment is that we've got a hilum on the right-facing side of the spleen, right here on its concave surface, and that's where the blood vessels are coming and going from the spleen. Its convex outer surface faces the ribs, and as it's noted here, we've got an area where it contacts the kidney, the transverse colon as it becomes the descending colon at the left or splenic flexure, and an area contacting the stomach. And the spleen is a bit of an oddball organ in that it doesn't actually do much in terms of digesting food, So what does it do? Well, if you're a little bit bored, you can click on this link. Some Harvard medical students a few years ago did a "What Does the Spleen Do?" video, which is basically a parody of the "What Does the Fox Say?" thing that got viral a little while ago. And if you missed that, you're not really missing much, but feel free to check that out for a little quick jolt of energy. So what does the spleen actually do? Well, it screens and filters blood. It helps form our lymphoid cells, and when it's screening the blood, it actually is looking for circulating cells that are problematic. Now, I said eliminates and deactivates bloodborne antigens. That should say bloodborne pathogens. So it's looking for things that are infecting our circulating cells and mounting an immune response to those. So things like mono will affect our circulating cells, and the spleen is actually one of the organs that's looking to screen for that and respond by eliminating those infected cells. It's the place where old and brittle platelets and red blood cells, erythrocytes, get recycled, and their heme groups and iron sent to the liver. And it's going to be a place where we actually form blood during early development. So it's a pretty important structure in terms of our vascular system. Here's a nice view of the spleen. Outside, convex surface faces the ribs, and on the inside, or the right-facing surface, we've got the hilum, where the blood vessels are coming and going, and there's a huge splenic artery going into this organ. A lot of blood since it's screening it, and not conversely, just as a result of that, we have a large splenic vein taking blood from it. It contacts, once again, the stomach, the left colic flexure, and the left kidney. So it's very closely intimate with those organs, and problems with the spleen can spread to those organs and vice versa. Now, if we take a look at the spleen, anyone who's hunted or dealt with raw liver, raw spleen, it's really floppy. There's not much that holds a shape here, and it's got a capsule that helps protect it, but it's really flimsy and it tears very easily. And in fact, since you can live without a spleen, the liver will pick up a lot of the functions of the spleen if it's removed. Sometimes if people are going to bleed out from a splenic rupture, the solution is not to try to fix the spleen because the capsule won't hold stitches. It's to just remove it altogether and ligate the splenic vessels. So that can be done. Compromises your immune system a little bit, but again, the liver can pick up a lot of the slack if it needs to. Inside the spleen, if you cut a fresh spleen, do a grossing on it, you will find there's kind of reddish areas and whitish areas. These white areas are near some of the vessels that are kind of ramifying throughout the spleen and branching, whereas there's reddish area called red pulp is a little bit of everything else that's left. So the red pulp and the white pulp are the keys to understanding the two different functions of the spleen. So here, if we have a blood vessel coming into the red and white pulp of the spleen, it diverts into what are called central arterioles. These are fairly substantial arterioles, and they're surrounded by white blood cells. These are called periarteriolar lymphoid sheaths, or PALs. And these are the T cells that are looking for specific antigens on the blood that's traveling through the spleen. So this is where we're actually screening circulating cells to see if they're cancerous, to see if they're infected with a virus, and see if there's some other circulating pathogen that's coming through. And then the T cells can mount a specific response against it. There are also B cells nearby, which can start proliferating to pump out antibodies if need be. But then, once the blood has been screened, it enters the red pulp of the spleen and the vessels nearby. And the vessels feeding the red pulp are kind of unique. Some of them, this is the current theory, some of them lead to these splenic sinuses that then consolidate into splenic veins and drain blood from the spleen. So if blood's traveling that way, it just travels through these kind of little baggy vessels in the spleen and then wind up going back into the venous system and going back into circulation. But some vessels don't actually go through and connect directly to the veins. Instead, they just dump the blood into this pinkish area, which is signifying the red pulp. So the blood's just spilling into the red pulp. And the red pulp is populated by macrophages, lymphatic cells that are screening those red blood cells. And it's kind of a rough neighborhood. If you're a red blood cell, this is where you don't want to wind up, because you've got a lot of macrophages just checking you out, trying to see if you are old and senescent and brittle, and they're basically going to take you out. They're going to lyse those old and inflexible red blood cells and platelets and release their heme groups, release their iron into circulation, and then the liver will take that iron on those heme groups and recycle them. Now, if that's just how it was, all the red blood cells that went up in the red pulp would be basically eliminated, but we want to give them a route to get back into circulation if they are flexible. Flexibility is the key for a red blood cell because what it has to do to negotiate capillaries is squeeze through tight spaces. And so if these red blood cells are relatively young and flexible, they're going to be able to work their way into those splenic sinuses. They're going to wiggle their way into these areas here. And the cells that make up these sinuses are actually flat and elongated, kind of looks like a barrel. There's some actual little fibers that hold them together like a barrel, but the red blood cells can squeeze through those gaps between the adjacent cells, and squeeze through the gaps in these sinusoids, get back into venous circulation, and then travel throughout the body thereafter. So that's how the spleen screens for old red blood cells and platelets and recycles the ones that can't quite negotiate those tight spaces anymore. All right, that's it for the organs. We're going to come back and talk about the blood supply, the origin of the abdominal organs, and we'll go from there. Keep studying hard. I'll see you guys soon.